Good morning, everyone, and thank you for joining us for today's Knockout Opioid Abuse Day Learning Series. This webinar series is a continuation of Knockout Opioid Abuse Day, which was designated as October 6th each year by Governor Murphy. And this learning series is designed to continue the awareness and education highlighted by that initiative throughout the year. Today's webinar, 1 year later, the opioid epidemic during COVID-19, is brought to you by the Partnership for a Drug for New Jersey, and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General. And I thank them for their partnership, their support, and collaboration on today's learning activity. Our featured expert speaker for today's webinar is Dr. Andrew Kolodny. He is the Director of Physicians for Responsible Opiate Prescribing. He's also the Medical Director of Opiate Policy Research Collaborative at the Institute of Behavioral Health, the Heller School of Social Policy and Management at Brandeis University. So we're really pleased and excited to have Dr. Kolodny with us. He actually spoke with us about 1 year ago about the opioid crisis at the beginning of the COVID pandemic, about what we could expect to see. And today he's going to be speaking to us again about the opioid crisis, how we got here, and what we've learned from this past year as together we've continued to address the opioid epidemic and addiction crisis in the midst of the COVID-19 pandemic. So Dr. Kolodny, thank you so much for joining us today. We're so pleased to have you, and I will now turn the presentation over to you.
Thank you, Angela. It's a pleasure to have this opportunity to talk with everyone again. I'm going to be speaking for about an hour, and then we'll try and save about 20 minutes when I'm done speaking for some Q&A. So let me get started. I'm going to begin by saying something that many people don't realize, including clinicians who prescribe opioids. When we talk about prescription opioid medications, drugs like oxycodone, which is in OxyContin and in Percocet, or hydrocodone, which is in Vicodin or Lortab or Norco. We talk about these drugs, we're talking about drugs that are literally made from opium. Existing naturally inside opium, which is the sap of the poppy plant, you have molecules like codeine, morphine, and thebaine. Those are the naturally occurring opioids. And another term for a naturally occurring opioid is opiate. From the opiates, the opioids that occur naturally, you can create other opioids. For example, you can create heroin, you can create oxycodone, hydrocodone, hydromorphone, which is Dilaudid, or oxymorphone, which is Opana. These opioids that you create from opium are also called semi-synthetic. Semi because they're partially natural. Not on this slide, though, are opioids that are completely synthetic. And these are drugs like fentanyl or methadone or tramadol or tapentadol, which is Nucynta. For those opioids, you don't need any opium to make them. They're just made chemically. So something to keep in mind is that the effects of the semi-synthetic opioids listed at the bottom of this slide are very similar. They all get into the brain rapidly, and produce effects that are virtually indistinguishable. An experienced heroin user would have trouble telling the difference between oxycodone and heroin, and we know this from studies that have been done. So when we talk about commonly prescribed opioids, in many ways we are essentially talking about heroin pills. Now, to make that statement doesn't mean that doctors should never prescribe opioids. These are very important medicines for easing suffering at the end of life. And they can also play an important role when used on a short-term basis for severe acute pain, for example, immediately after major surgery or a serious accident. Unfortunately, though, the bulk of the prescribing, the bulk of the consumption in the United States is not for end-of-life care or immediately after surgery. The bulk of the prescribing is for conditions where there are better options than opioids and where opioids may be more likely to harm the patient than help the patient. This is a very old slide that I think the CDC came out with this slide in 2010. And when they came out with this slide, there was about a 3-year lag in drug overdose death data. They came out with this slide at a time when they had just began calling the opioid crisis, actually using the term epidemic to describe the opioid crisis. And in 2010, when the CDC started to refer to the problem using the term epidemic, they began to get criticized. Much of the criticism was coming from pain organizations that were taking lots of money from drug companies like Purdue Pharma, the maker of OxyContin, and taking money from other drug makers. They began to attack the CDC for using the term epidemic. They told the CDC, you're exaggerating, it's not an epidemic. And they said by using that term, you're going to scare doctors away from prescribing opioids. And the CDC responded in part by creating this slide to make a point. What they're showing us on this slide is the rate of drug overdose deaths during the height of the heroin epidemic in the 70s, which you see on the left. And then they're showing you the rate of drug overdose deaths during the height of the crack cocaine epidemic, which was the late 80s, early 90s. And they're showing you what's happening with drug overdose deaths, excuse me, what's been happening with drug overdose deaths since. And you can see that they've just continued to go up rapidly. So what the CDC was really saying here is that not only is this an epidemic, it's the worst drug overdose epidemic in United States history. And this is an old slide, so I just kind of quickly want to show you what's happened since in terms of drug overdose deaths. In 2007, they went up. 2008, they went up again. 2009, 10, 11, 12, 13, they just have kept going up and up and up. In 2018, we saw a bit of a pause, and it looked like, hey, maybe we were going to peak and maybe overdose deaths would finally start coming down. And unfortunately, they just kept going up higher. And what we've experienced during COVID has been an even sharper increase. So we were already at historically high levels. The rate of deaths had been going up, and as COVID hit, and I'll show you some of the data in a moment, the rate of deaths went even higher, unfortunately. So up until 2010, what was driving the increase I just showed you on the previous slide, because the previous slide wasn't showing you the specific drugs, it was just showing you all drugs. So here you're looking at the breakdown of specific drugs involved in deaths up until 2010. And what you see very clearly is the red line, which is prescription opioids, were the main driver up until 2010. Heroin, which is obviously an opioid, is listed at the bottom, and there had been a slight increase, but heroin deaths had not really been rising rapidly. And so almost entirely, the problem was being driven by prescription opioids. After 2010, the picture began to change in a pretty dramatic way. On this graph, the prescription opioids are the dark blue line. And you can see what I was just showing you, that up until 2010, they were the main driver. And then around 2011, it levels off, stops really going up as rapidly. And in 2012, do you see the gray line that goes up? That's heroin deaths increasing. And then in 2013, do you see this orange line that begins to take off and really skyrockets? Those are primarily illicitly synthesized fentanyl deaths, labeled here as synthetics other than methadone. And it's really been this sharp increase in fentanyl that has resulted in the large increase of overdose deaths that we've seen in the past few years. And the sharp increase that we've seen during COVID has been primarily due to fentanyl as well. Now, there are many people who are looking at this slide that I'm showing you, who are looking at these trends, and they're drawing the wrong conclusion. A very popular narrative to explain what we're looking at is to suggest that the reason that we saw this, that deaths were primarily driven by prescription opioids up until around 2010, 2011, and then illicit opioid deaths begin to take off. The explanation for that we often hear is that there was a crackdown on the pills, and that forced so-called drug abusers, it's a term I don't like, but that's the narrative, that the drug abusers switched from prescription opioids to illicit opioids because of a sudden crackdown on the pills. And it is very true that around 2012, opioid prescribing does start to trend down. So one could say, well, hey, as prescribing is trending down, the deaths involving illicit opioids are going up. And so that, A is causing B. That's not really what's been going on. And in fact, the rise in use of heroin was happening as prescription opioids were skyrocketing. So use of heroin and switching from prescription opioids to heroin was happening as prescribing was still going up, and as prescribing was at record high levels, we were seeing more and more use of heroin, and I'll explain that. I want you to begin by looking on the right side at the graph on the right. And what you're looking at is data based on people seeking treatment or receiving treatment for addiction to heroin. And on the right graph, you're looking at blacks. On the left graph, you're looking at whites. And if you look, I really want you to zero in on the red line in both graphs. Now start by looking on the right, you'll see for blacks ages 20 to 34 years old, you see it really shows even a decline in use of heroin among young Black people in the United States. That's a trend that's been in place for well over 30 years. Both crack cocaine and heroin, initiation of these drugs among young non-whites in inner city communities has been on the decline. You still have heroin use and crack cocaine use in inner city communities that are a very serious problem, which we'll talk about in a minute. But among young people in these communities, there really has been decreasing initiation of those drugs. It's an older, aging cohort that struggles with their addiction, people affected by prior epidemics. If you look at young white people in the United States, 20 to 34 years old, you just see a soaring use of heroin. And again, that rise in use of heroin or in people seeking treatment for addiction to heroin, that's happening as the prescribing is taking off at levels like we had never seen before. So why were they switching? Why were these young people switching from prescription opioids to heroin if prescribing was still rising? Well, these were young people who became opioid addicted pretty much in one of three different ways. They became opioid addicted taking prescription opioids to enjoy the effect, basically using them recreationally. They did that too much and they got hooked. That's one way they became opioid addicted. The second way that they may have become opioid addicted is through medical use. Another term for that is iatrogenic addiction. Iatrogenic meaning caused by medical treatment. So this could be a young person who may have experienced a serious accident or has a chronic medical problem, was prescribed opioids very aggressively and became addicted through those prescriptions. And then the third way, which I think is probably the most common way that young people become opioid addicted, is almost a combination of the first two that I just described. It's basically a young person with a brief medical exposure maybe wisdom teeth or sports injury. They were prescribed opioids short term, very briefly. They didn't become addicted from that exposure, but they basically got their first taste of the drug from a doctor or a dentist, and they may have liked the effect. They're certainly not afraid of it because it was prescribed to them. They took it and it didn't hurt them. And after that medical exposure, and it could be immediately after or it could be a few years after that medical exposure, there's a period of recreational use that then results in addiction. Now, when these young people become opioid addicted, even if their opioid addiction began because they were taking opioids because they liked the effect, once you become opioid addicted, what drives continued use more than anything else is not that it feels good to take an opioid, it's that it feels awful to stop taking the opioid. And when I say awful, I'm not just referring to the flu-like symptoms of opioid withdrawal. There are also very severe psychological symptoms. People feel intense anxiety when they start to run out of opioids. It feels like a panic attack. People feel like they're going to die. And so they'll be very desperate to maintain their opioid supply. These young people who become addicted to prescription opioids have a very hard time maintaining their supply visiting doctors. And even in the early 2000s, if a young, healthy-looking 25-year-old visited a doctor and they wanted to get a large supply of opioids to take on a monthly basis for a complaint of chronic pain, even in the early 2000s, unless a doctor was a drug dealer, and unfortunately some have been, unless a doctor was a drug dealer, they really didn't want to give healthy-looking 25-year-olds lots of opioids every month. So that young person would wind up on the black market. The pills have always been very expensive on the black market. Back in 2003, an 80 milligram OxyContin sold on the street for $80 a pill. If that young person was in a region of the country where heroin was available, they'd switch because heroin is much cheaper and produces the same effect. And what we've seen happening pretty steadily over the past 20, 25 years is we've seen heroin move into more regions of the country where it wasn't previously available to meet the demand for it by this growing number of young people who became addicted to prescription opioids. Now, I want you to look now at the green line on the left, white people 45 years and older. What you really don't see there is rising use of treatment seeking for heroin. That does not mean, unfortunately, that middle-aged white people in the United States have been spared from the opioid crisis. In fact, it's a group that's been hit especially hard. So why hasn't heroin use risen among older white people in the United States? The main reason there is that this is a population that has been able to get prescription opioids much more easily from doctors. Middle-aged and older people with multiple medical problems, with legitimate chronic pain problems, generally are able to get very aggressive prescriptions from doctors on a monthly basis. And even when these patients might start to become addicted, maybe they're coming in early, asking for higher and higher doses, very often the primary care doc or the geriatrician doesn't want to put a label like addiction on the patient. And when they get referred, if they get referred anywhere, it's often to pain management, where it's pretty hit or miss in terms of whether they'll land on a pain management doctor that's going to try to get them off of their opioids or at least reduce the dose of opioids and address their pain with other modalities. In some cases, they land on a pain management doc who has no qualms about going even higher on the dose. Before fentanyl emerged, when you looked at the rate of drug overdose deaths among young people in the United States who were switching to heroin, or the older group that was able to get pills more easily from doctors, at that point in time, we were actually seeing significantly more deaths in older Americans who were able to get pills more easily from doctors. OPR is opioid pain reliever. The light blue bar on this graph is opioid pain reliever deaths. The dark blue is heroin. And you could see the age grouping at that time where there were the most deaths were the middle-aged group, and it was mostly prescription opioids. If you looked just at heroin, you'd see more heroin deaths in that younger group. This, of course, all changed after fentanyl emerged. Let me very briefly go over the epidemiology of opioid use disorder, which is something that I think really gets neglected when policymakers look at our opioid crisis or try to come up with strategies to address it. We roughly speaking have three groups of opioid addicted Americans. I've just told you about the first two. It's a group that's disproportionately white that became opioid addicted after 1995 and has been switching to heroin. The second group is this middle-aged group that's also disproportionately white. They're middle-aged and older. They also became opioid addicted after 1995. It's a group that hasn't really been switching to heroin. It's the group where before fentanyl emerged, we saw more of the deaths. And the third group is a group that gets the least amount of attention. It's a group that's disproportionately Black and Latino. These are people 50 and up. This is a group where their opioid addiction began before 1995. It often began with heroin. They didn't switch to heroin. And what's happened since fentanyl emerged and what's gotten even worse during COVID is that deaths in this first group and this third group, basically deaths in heroin using populations, have skyrocketed over the past few years, which is why we've seen the very sharp increase in an already high death toll from opioids. This is just showing you a little bit of what I'm talking about. Excuse me. So what you're seeing on the left again would be white people, on the right would be Black people. And this is data again from treatment admissions. And it's showing you this cohorting effect that I was just describing. And you could see for white people receiving treatment for heroin, you see a little bit of a shift to the right as this group is beginning to age. But you also see an increase in the size of or really the number of people receiving who are getting treated for heroin. And that's that young group that is disproportionately white that I just described. That's the first group on the previous slide. The third group on the previous slide is on the right. And this is, these would be Blacks. On the top right is Black men, on the bottom right is Black women. And here too, you see a shift to the right as this cohort ages from the 2000 to 2002 range up through the 2015 to 2017 range. And so here, this is basically what I'm referring to when I talk about the different populations of people with opioid use disorder. When you look at the death toll from fentanyl, you see here that if you look to the right, the toll has been the greatest for young whites, which is that blue line at the very top, and the purple line would be Black men in their 50s. You do see we had a fentanyl outbreak in 2006 that disproportionately hit inner city communities and disproportionately affected Black heroin users. The DEA was able to trace back that fentanyl outbreak to a lab in Mexico, and they shut it down. And we didn't really have that much of a problem with illicit fentanyl again until it reemerged in 2013. So this is showing you the most current data available, and it's a glimpse of what's been happening with drug overdose deaths since COVID. And if you look on the right, and if you look at sort of January 2020 and then look straight up, the very thick black line at the top is showing you total drug overdose deaths from all classes of drugs. And you see that black line tracks very closely with the brown line below it, which is fentanyl deaths. And what you'll see here from this graph is that, before COVID hit, we were already seeing a significant rise in fentanyl deaths. But after COVID hits, you see that the problem continues to get worse and really speeds up during COVID. And I'll talk a little bit more later about why that may be the case. And here we're just zeroing in. This is showing us the most current data available. and this is the fentanyl deaths. And if you look from like around January 2018 till around January 2019, the rise in fentanyl deaths was pretty slight. And because during that period of time, there was a drop in deaths involving both prescription opioids and heroin were going down, and because fentanyl had only increased just a bit, overall for the 2018 year, for the first time, we did see a slight drop in deaths involving opioids. And that's why it looked like maybe we were rounding the corner. But then you see the fentanyl deaths start to pick up again rapidly. And I'll explain what's going on. Initially, the fentanyl deaths were very much an eastern half of the United States problem. The geographic differences here are striking, how limited the fentanyl problem really was to the eastern half of the United States. And fentanyl, something many people don't recognize, was really disproportionately impacting urban areas where that third group, the disproportionately Black and Latino group, was most affected. In fact, the geographic area in the United States hit hardest by fentanyl up through 2016 was inner city Washington, D.C. Was hit hardest, and it was D.C., Baltimore, North Philly, South Bronx, Central Brooklyn, communities that had really been struggling with heroin for decades before the current opioid addiction epidemic were hit very hard by the rise in fentanyl. But what's happened since and really sped up during COVID is that fentanyl, I don't want to say that it spread to the western half of the United States, because that would sound like it moved from east to west. It didn't really move from east to west. It really moved from Mexico to the western half of the United States. Initially, most of the fentanyl that was coming in was coming from Mexico, and it was heading to the eastern half of the United States. And what starts to happen is that we start to see the fentanyl not just coming to the eastern half, but it also starts to spread to the West Coast. And so here you're just looking, I picked a state, I picked Oregon, so that you can see what's really been going on as an example, a state in the western part of the United States. And again, fentanyl is brown. Look at the brown line at the bottom of the graph. You could see that up until 2020, up until COVID really hitting, there were more deaths from prescription opioids and heroin. Prescription opioids is green, heroin is blue. So you start to, so really in Oregon, fentanyl was not the #1 opioid killing people. But after COVID hits, you start to see fentanyl take off. It really surpasses prescription opioids, then it surpasses heroin as the leading opioid. And then if you look at the top of the graph, what's happening total for drug overdose deaths, you see it really tracks with the fentanyl. Note at the gray line here is methamphetamine. And in the western half of the United States, there's been a sharp rise and in some states in the US, not just in the western half of the US, methamphetamine deaths have also been going up in part because there's been an increase in the potency and purity of methamphetamine. So this is an example of what I've been referring to. And why have we seen fentanyl spread more? It's a spread that might have happened without COVID, but one possible explanation is that when COVID hit, there was much less cross-border traffic, less people traveling, less people flying, less people coming across a border. And it may have favored the smuggling of a drug that's less bulky. And it's not that heroin is a very bulky illicit drug to bring across a border. It's far less bulky than cannabis. It's less bulky even than cocaine. But fentanyl is much more potent than heroin, and so it's much easier to smuggle a significant quantity of fentanyl, a much greater morphine milligram equivalency in fentanyl than in heroin. And so that may have favored bringing in more fentanyl and less heroin, which may have sped up a trend that was already happening. Let me talk quickly about framing of the opioid crisis, because it's just something over and over again I see people really don't understand and often gets missed in the conversation. You know, how should we frame the opioid crisis? Too often I hear the problem framed as an overdose death crisis, which I really think is a mistake. That would be like framing the COVID pandemic as an epidemic of multi-system organ failure, or an epidemic of septic shock, which is really what people are often dying from when they have COVID. Overdose death is what people are dying from who have opioid use disorder. The right way to really frame this epidemic is as an epidemic of opioid use disorder. I'm not suggesting now that everybody who dies of an opioid overdose had opioid use disorder. There are many deaths in people who were not opioid addicted, but studies of opioid overdose decedents really do show us that the vast majority of individuals dying of opioid overdoses were suffering from opioid use disorder. There's strong evidence that really is the large majority of the deaths. And so, you know, the correct way to understand all of the health and social problems that, you know, we're referring to when we talk about the opioid crisis, the correct way to understand the rise in the deaths, the rise in infants born opioid dependent, children flooding into foster care, the impact on the workforce, the flood of heroin and fentanyl into non-urban areas. Really the driver behind all of these health and social problems has been a very sharp increase in the prevalence of opioid use disorder. From 1997 to 2011, a 900% increase in the number of Americans seeking treatment for addiction to prescription opioids during that time frame. So really the correct way to frame this is as an epidemic of opioid use disorder or opioid addiction. I can tell you that from the opioid industry would like to frame the opioid crisis as a drug abuse problem. They want us to think that so-called drug abusers are this homogenous group switching from one drug to another, and which is why they especially like this narrative that a crackdown on the pills caused these drug abusers to switch over to a more dangerous supply. But this really isn't a drug abuse crisis. It's certainly true that some people have become opioid addicted because they abused opioids. They took opioids because they liked the effect, and that's how they became addicted. But as we've discussed, many people became opioid addicted taking opioids as prescribed by doctors. And regardless of how you become opioid addicted, once you become opioid addicted, it's not the fact that this feels fun or abuse that drives the continued use. It's that people feel really sick without the drug. So again, the correct way to frame our opioid crisis is as an epidemic of opioid use disorder. I'm going to show you that happening. So, you know, the opioid addiction epidemic began in the year 1996. You'll see why I say that in a minute. That would mean that this is 3 years into the epidemic. And the states on this map that show up as red or maroon are the states with the highest rate of people seeking treatment for addiction to prescription opioids. I want you to see what happens to the map as we go forward in 2-year increments. So this is 99. This is 2001. This is 2003. This is 2005. This is 2007. And this is 2009. By 2009, in just about every state in the country, we had experienced a very sharp increase in the prevalence, the number of people suffering from the condition of opioid use disorder measured by treatment seeking. And when you have a sharp increase in a disease over a short period of time, that really is an epidemic. So what caused our opioid addiction epidemic? There's a really important clue on this graph. This is a graph showing you oxycodone consumption in the United States compared to oxycodone consumption in Europe. And this is on a per capita basis. And so the important clue I'm referring to is you can see the actual year that the oxycodone prescribing takes off. And that's the year 1996. And some of you may know that 1996 was the year that OxyContin hit the market. And you may look at this graph thinking, well, okay, so this is all about the introduction of OxyContin by Purdue Pharma and the Sackler family. And largely that is what you're looking at here. You're looking at the introduction of a lot of that increase in consumption is OxyContin. It's also the immediate release 30 milligram oxycodone, a product introduced by Mallinckrodt. But yeah, it was the actions taken by Purdue Pharma, the Sacklers, and other opioid manufacturers that all get going around 1996 that resulted in this very sharp uptick in not just oxycodone, but hydrocodone, morphine, hydromorphone, oxymorphone, fentanyl. Every opioid that was on the market before 1996 really starts going up pretty rapidly in 1996. 1996 was the year that a multifaceted campaign was launched to change the way opioids are prescribed in the United States. Now, some of you who may know a little bit of this story and may understand that states are suing opioid manufacturers right now for their role in the opioid crisis. And I've had the pleasure to help states in some of these cases against the opioid industry. Some of you may understand that at the root of the litigation is the idea that the medical community changed the way it was prescribing because of the marketing. And if you're skeptical, I don't blame you if you're saying, well, how could doctors have been that gullible to have fallen for marketing so easily? How could doctors who go to medical school who are supposed to be smart fallen for this idea that a drug like oxycodone is not addictive? What you need to understand is that those messages were not just coming to the medical community from the drug companies directly. It wasn't just the attractive sales reps who visit us in our offices and push products and can be quite charming and buy lunch for your medical staff and schmooze you and tell you how wonderful their products are. They certainly do have an impact on the way products are prescribed, but if it was just the drug reps, I think the medical community would have been less gullible. The messages that we needed to prescribe more opioids were coming to us from pain patient organizations funded by industry, from professional societies that launched, for example, the American Pain Society launched the Pain is the Fifth Vital Sign campaign, which was adopted by the Joint Commission, which regulates hospitals. Even state medical boards were hearing from their trade association, the Federation of State Medical Boards, that there's a chilling effect in America, that doctors want to prescribe more opioids, but they're worried they'll get into trouble if they do. And so from every different direction, the medical community was hearing that if you're an enlightened, compassionate doctor in the know, you're going to be different from those stingy, puritanical doctors of the past who were allowing patients to suffer needlessly. You'll understand that opioids are a gift from Mother Nature and should be used much more for just about any complaint of pain. And as the medical community responded to this campaign and as the prescribing took off, it led to a public health catastrophe. So, I mentioned this campaign that told doctors that we didn't have to worry about getting our patients addicted. The statistic that was used over and over again, cited hundreds of times, was that much less than 1% of patients put on long-term daily opioids would become addicted. That statistic appeared in journal articles, it appeared in lectures, it appeared in textbooks, it was cited by the press. Over and over again, we're hearing much less than 1% of patients will become addicted. Now, I want you to imagine for a moment that you're a young doc, you're recently out of your medical training, and you come across this statistic in a textbook: much less than 1% of patients will become addicted when put on long-term opioids. And it strikes you as strange because you can still remember your medical school pharmacology, and you know that that oxycodone molecule is a lot like that heroin molecule. How can you put patients on a drug so similar to heroin for weeks and months and years, and much less than 1% will become addicted? It strikes you as very strange. So what do? You turn to the back of the chapter to look at the reference for this statistic. And what you would see at the back of the chapter to support the statistic was Porter and Jick, Addiction Rare in Patients Treated with Narcotics, New England Journal of Medicine, 1980. You know, it's in the late 90s through the 2000s, everybody's citing this to prove we don't have to worry about getting our patients addicted. Now, this looks pretty good, and you might just stop there. New England Journal of Medicine is one of our best medical journals. But let's say you really want to know what they did in this study, because you're not buying it. So you go online, you go to a website called PubMed. You figure you'll type this in and read the summary of the study at the least. And you type it in and nothing comes up, which really seems strange because usually you can get a summary for an article in PubMed. You type it in again and again, nothing comes up. You're thinking, gee, maybe it's just too old. Maybe PubMed doesn't go back that far to 1980. But that wasn't it. So you make your way to the medical library. You pull out the 1980 volume of the New England Journal of Medicine because you really wanted to know what was done in this study. What you would find out, well, you'd find out immediately why there was no abstract on PubMed. What you'd find out is that what everybody was citing wasn't actually a journal article. It was a letter to the editor. This is the whole thing. This is Porter and Jick. This had been described as a landmark study that proved we didn't need to worry about getting our patients addicted. It's a one-paragraph letter to the editor describing chart reviews of 11,882 charts of hospitalized patients, where they only found 4 charts of patients who, while in a hospital bed, were given an opioid like morphine or Demerol. They only found 4 charts where a nurse or a doctor had documented that a patient suddenly appeared drug-seeking after getting a dose of an opioid. This tells you nothing about the risk of addiction when a patient is put on long-term opioids, but this is what was used over and over again as evidence that we don't have to worry about getting our patients addicted. We have really good evidence that daily long-term use of opioids is harmful to patients, but we actually don't have good evidence that it's effective. There's very good reason to believe that long-term use of opioids is more likely to make pain worse, a phenomenon called hyperalgesia, than to actually be effective for people suffering from chronic pain. This is an evidence review that was done in 2015. There's an evidence review that was just done again by the federal government with a very similar finding. So for any treatment where you don't have evidence that it helps patients, but you have evidence that it's dangerous, those are treatments that should be prescribed rarely. Opioids, unfortunately, are still routinely prescribed in the United States. Prescribing has been trending in the right direction, but we still continue to massively overprescribe opioids for conditions where they're not safe and effective. We prescribe opioids much too aggressively for acute pain as well. This is a study published by the CDC that looked at the probability that someone would wind up stuck on opioids a year later based on how aggressive the first prescription was. And no surprise, if you were prescribed too many opioids at the outset, you were more likely to be on opioids. A patient who took opioids every day for 10 days, 1 in 5 remained on an opioid a year later. Patients who took opioids every day for 30 days, about 40% were still on an opioid 1 year later. How do we bring our opioid addiction epidemic under control? Well, I went out of my way to frame this as an opioid addiction epidemic, meaning I framed it as an epidemic of people with a preventable, treatable disease. And so the main things we have to do about our opioid addiction epidemic are very similar to what we need to do about COVID or any kind of disease epidemic. You have to focus on preventing people from getting the disease and seeing that people who have the disease have access to effective treatment. With a drug addiction epidemic, there is also a role for closing down pill mills and for making heroin and fentanyl harder to obtain on the black market. If you can make treatment easier to obtain and illicit opioids harder to obtain, many more people, I strongly believe, will seek treatment. Let's talk a little bit about the impact of COVID in the remaining 10 minutes, and then we will then I'll take some Q&A. So what we have seen is a significant increase in overdose deaths during COVID. There was a rise, there was a trend prior to COVID, but that trend in overdose deaths, particularly deaths involving fentanyl and also methamphetamine, sped up during COVID. The ability to treat people with opioid use disorder may have been impeded, so that and not just formal treatment, but people with drug and alcohol problems who might have been very stable in 12-step meetings. A 12-step meeting that shifted to Zoom might not really have been able to provide the same support for individuals. And for people with drug addiction who become socially isolated, there's reason to believe that can make their addiction worse. And that does seem to have happened to many people. With COVID hitting, it put a halt on the litigation that had been launched across many of the states. So it is possible that without COVID, some of these cases might have already reached a judgment or a settlement where money would become available to counties and states to expand access to opioid addiction treatment, assuming that money wouldn't get clawed back by a state legislature, which is a pretty big if. But all of the litigation also got halted. There are reasons to believe that individuals with opioid use disorder are more susceptible to COVID. And that's both because of the biological effects of opioid use. Opioids are immune suppressants. And this is true whether you're a heroin user or whether you're a pain patient on long-term opioids. If you're taking opioids chronically, they suppress the immune system and make you more susceptible to a variety of diseases, including cancer, because actually our immune systems protect us as well from the development of cancer. So chronic opioid use can also increase the risk of cancer, but certainly could make you more susceptible to developing infections with COVID and to developing a more severe infection with COVID. The psychosocial factors that can result from addiction, whether it's homelessness or whether it's winding up in a rehab, can also increase the risk of contracting COVID. And as I mentioned, the risk of a more severe case of COVID is also greater for people with opioid use disorder because of the effects on the immune system, the effects of opioids on respiration, and the other medical comorbidities that affect people with opioid use disorder. We have now some pretty good evidence that people with opioid use disorder that the impact of COVID has been far greater. We saw a more significant impact on people with substance use disorders in general, but with the greatest being for people with opioid use disorder, followed by tobacco use disorder, had the highest risk. And among people at the greatest risk for death from COVID, again, people with substance use disorders were at greater risk of death. Among people with substance use disorders, it was primarily opioid use disorder. And among people with opioid use disorder, Black patients with opioid use disorder were at the highest risk of dying from COVID. We did see some treatment system changes that relaxed a bit that I think were necessary. So take-home rules for methadone maintenance eased up a bit. The ability to induct or initiate buprenorphine treatment for people with opioid use disorder improved because that was allowed now through telehealth or telemedicine. We did see an expansion of some telemedicine treatment programs, and even naloxone in some cases became available for home deliveries. And it is possible that some of these relaxing of the rules are good and should be maintained. Others, it's harder to say. There's advocacy right now for getting rid of other regulations related to buprenorphine, like the X waiver, which is something the Trump administration almost did on its way out the door, was to get rid of the 8-hour training requirement and the X waiver for buprenorphine prescribing. And unfortunately, that change was reversed by the Biden administration. My understanding is that the Biden administration thought that change needed to be made through legislation. Hopefully we'll see that legislation. I do think that would be a very important change. Some people are also advocating for methadone maintenance or for methadone to for docs to be able to prescribe methadone for opioid use disorder from primary care, the same way we do for buprenorphine. That might not be a great idea. Unlike buprenorphine, methadone is a drug that people can very easily overdose on. So there is a greater rationale for some restrictions on how that medication is administered or dispensed. So it's harder to say whether or not the relaxing of rules on methadone is as good an idea as relaxing some of the restrictions on buprenorphine. We have a study just published today. I think the embargo just lifted today on this study that looked at long COVID patients, basically survivors of COVID who now appear to have a whole host of medical problems. And one of the concerning findings in this study was that individuals who are suffering the after effects of COVID, there seems to be a significant increase in initiation of opioids for this population, which is very concerning because it suggests that many in the medical community still don't get it, that they still think opioids are appropriate drugs for long-term use. And lastly, let me just finish up here with, in the remaining few minutes, on what can we learn from COVID that could impact our ability to address the opioid crisis. Well, it's hard to look at the response to the COVID pandemic and talk about what we've done right, because there's so much we did wrong, and it's very likely, had the United States and other countries responded appropriately when the outbreak began in China, that COVID could have been that we would have had a much better response and would have seen much less morbidity and mortality. So you could say, hey, how can we learn from that? We failed miserably. But one of the things that I look at and in some ways makes me wishful for the opioid crisis is, at least with COVID, we've had very good surveillance of this problem. So on a daily basis and on a county level in the United States, we know how many Americans are testing positive. We know the positivity rate in the testing. We know the number of hospitalizations. We know the number of deaths. We know the number of discharges. All of this allows us to closely track what's happening and to potentially adjust a public health response based on this surveillance data. We are now 25 years into the opioid addiction epidemic, and we have the awful surveillance. We have next to no surveillance on the opioid crisis. The best data we have is on the overdose deaths, and even there, year-old data is still labeled provisional. We have no public health surveillance data to tell us how many people are still becoming newly addicted to opioids. No data to really give us estimates on the prevalence of opioid use disorder nationally. We have a figure that comes from the National Survey of Drug Use and Health, but it really isn't a prevalence estimate for opioid use disorder. And if we don't have good evidence, if we don't have good estimates of incidence and prevalence, if you don't know which counties, for example, are hit hardest, how do you direct the resources to where they're most needed? If you don't have good incidence data, how do we know how to adjust our efforts to prevent people from getting opioid use disorder? So I really do think that, if there's any lesson we should learn, it's that we need to immediately improve our surveillance of the opioid epidemic. So I'm going to end here. In summary, we're in the midst of the worst opioid addiction epidemic in US history, which only got even worse during COVID. To bring this epidemic under control, we have to prevent more Americans from developing opioid use disorder, and we have to see that those suffering from the condition have access to effective treatment. Thank you.
Thanks so much, Dr. Kolodny. It was a really eye-opening presentation. I know, as I've seen in the feedback we've been receiving in the chat, lots of good information that was appreciated. We did have a few questions. I know many of them were addressed in your presentation, but I'll start off with a kind of a generic one for your opinion. What do you find is the most effective non-opioid alternative available to treat pain?
Well, a very effective non-opioid analgesic, and for many people with pain, I should say that the approach doesn't involve an analgesic. Many people, for example, with what has recently been defined as by an international pain or professional pain group as primary pain. That's pain where you can't find a medical cause for it. Conditions like fibromyalgia, really, if anything might be prescribed, potentially it's an antidepressant, but really analgesics are not the answer. And there are many other medical problems, even pain problems that do have an identifiable cause, where the approach is non-pharmacologic, for example, involves physical therapy. But for the pharmacologic approaches, many people don't know this, but the class of analgesic referred to as NSAIDs are as effective, and in some cases potentially more effective than opioids, even for excruciatingly painful conditions like renal colic. It's also called kidney stone pain. NSAIDs have been shown to be as effective as opioids. Now, not every patient can take NSAIDs, non-steroidal anti-inflammatory drugs, which are drugs like Advil, for example, or Aleve. Some patients have medical problems where they're not able to take an NSAID, and sometimes for severe acute pain, there is a role for opioids, but that should always be very short-term use, or if it's ever prescribed for a chronic pain condition, intermittent use, meaning not taken every day. Because when opioids are taken every day, quickly patients develop tolerance to the pain relieving effect. In order to continue to get pain relief, doses have to go up. As doses go up, you often see level of function decline. And of course, as doses go up, this becomes dangerous. And you're talking about putting a patient on a medicine that could be very hard for them to ever come off, even when it starts to make their pain worse. Tylenol is not as strong a pain reliever as NSAIDs, but for some people can be pretty effective. And fortunately, you can actually combine a drug like Advil with a drug like Tylenol, acetaminophen, because they work differently. So as long as a patient's able to take a Tylenol and is able to take Advil, because as long as they don't have a contraindication to taking those medications, they can even be combined. And the combination of Tylenol and Advil is actually first line for wisdom teeth removal, even though in many cases dentists are often still give drugs like hydrocodone or oxycodone to teenagers when their wisdom teeth come out. Tylenol and Advil combined gives better pain relief with less side effects.
Oh, thank you. I want to mention there is a poll that was launched, and if everyone can fill that out and just give us some feedback on today's presentation, we would appreciate it. So Andrew, just following up on what you just said, can you speak again and expand upon how the fentanyl epidemic that you discussed is being driven perhaps by the introduction and continued prescribing of opioids?
So, yeah, that's an interesting question. So prescribing is starting to trend in the right direction, and which I think means that the incidence rate of opioid addiction is also trending in the right direction, meaning that I think less Americans are becoming newly addicted to opioids since around 2012. If we had that number, if we had adequate surveillance, and there's some evidence that this is happening, I think that number would be going down. But because opioids continue, even though the trend is in the right direction, but because we continue to prescribe too aggressively, we continue to prescribe far more opioids than any other country on earth. We continue to prescribe far more opioids than we were prescribing before we had an opioid addiction epidemic in the early 90s or 80s. Because we still overprescribe, I think that means many people are still becoming newly addicted. And for people who become newly addicted and have to maintain their opioid supply, a good number wind up on the black market, where we have just an exceptionally dangerous illicit opioid supply because of fentanyl, which puts these individuals' lives at risk. So I think to really address this in the short run, this soaring increase we've experienced with fentanyl overdose deaths, I think the main approach isn't preventing new cases of opioid use disorder to bring down the deaths in the short run. It's about treating people who already are opioid addicted and seeing that they have much, much easier access to treatment. It has to be easier to find a doc who can get you stabilized on buprenorphine in the United States and virtually free for that to happen. Then that has to be easier than it is to buy a bag of heroin or fentanyl or access pills from a pill mill. And if we get there, if we get to a point where the treatment is easier to get, I really do think we'd see deaths coming down rapidly.
All right, thank you so much. Just one final last thought. Could you give us some feedback? Just what would be the one lesson you think we've learned from the past year, and also what we can do better as we still are dealing with this epidemic within the pandemic?
Yeah, I think that for some people who don't understand the disease of addiction, might have thought when COVID hit that for people addicted to opioids, that they'd pull themselves together, that they'd hunker down with their families and socially isolate, and that maybe their drug use would decline or get better because we're in the midst of this national emergency of COVID. But that's not how addiction works, and there would have been no reason to think that someone who has opioid use disorder is going to necessarily just get better, and many reasons to think that the stress and the social isolation would drive people who have a substance use disorder, would actually, even in many cases, cause relapses in people who might have been in remission. And the fact that we've seen a greater death toll, I did talk about the role that fentanyl played in a more dangerous supply, but it is also likely that the psychosocial stress of the pandemic has also made people has really worsened the severity of people's opioid use disorder. And so I really think this has to remind us that opioid use disorder is a chronic, life-threatening disease that has to be treated, or often you'll see terrible outcomes.
All right, well, I thank you so much again for your presentation today. I know we've come to the end of our time, but I just want to mention that if anyone has any additional questions that they have that they feel were not answered, feel free to email us and we'll try to get an answer for you. And also a reminder that a recording of this presentation as well as the slides from today will be shared with you. Again, Dr. Kolodny, thank you so much for being with us, and thank you for all of our attendees for joining us today.
Thank you for having me.
Thank you. I wish you all a good day. Stay well, and I hope that you can join us for our May webinar, which is going to discuss the alternative to opioids program that was started at St. Joseph's Hospital. So information is in the chat feature on that as well. And if there's anything, we'll be also sharing information with you in an email. Thank you again, and have a good day, everyone.